Okay, welcome back. And in the second part, we'll start talking about the functional anatomy. So the TM joint is a synovial joint, and it conducts two movements: the hinge movement or rotation, and the gliding movement. So the hinge movement is just when the joint just rotates in place, and this is adequate to open your mouth, or about 20 to 25 millimeter maximum. And this, and then it needs to slide or glide down the eminence or the articular eminence, and we call this the translation movement that would open the mouth widely. And the joint is peculiar in the TM joint in the form that it is the only joint that has an endpoint of movement. So you can open your jaw, so you open with the rotation and then gliding movement, and there is ligaments that would restrict your mouth opening. It is restricted by the muscles of mastication, by the collateral ligaments, and other ligaments that binds the joint to the skull. And when you close, you can close to just until your teeth touches, so you cannot close further. So it has an end point in both directions, which is different than the other body joints. This is one thing. The other thing is we have the two joints are connected. So there's two joints that open together, close together, move together, and they are related, which we do not find in any other joints of the body. So it has its own structural and anatomic specifications. If we look in more details in the structure of the jaw, you can see that this is the condyle, and this is the articular eminence, and between them, to make the movement sort of smooth, we have an absorber, a shock absorber, which we call the articular disc. And this articular disc has this shape with a thick ending or thick posterior part and thick anterior part, and in between a thin part. This shape of the disc will provide stability to the joint. It will provide stability to the location of the disc over the joint. And this disc would separate the cavity that is, or the space that lies between the condyle and the eminence, or the fossa when the jaw is closed. So we have the upper compartment and lower compartment, and the synovial fluids move within this compartment again to provide nourishment, to provide lubrication, and to provide shock absorption to the area. So many patients who keep clenching their jaw, so they are squeezing the disc between the fossa and the condyle, and because of that the synovial fluid would not be able to move and lubricate the area. We would not be able to nourish the area, and this is why we start seeing temporomandibular joint dysfunction. So this is how a healthy joint would look like, and this is the importance of the disc to provide protection and proper movement of the joint. So this is how things looks like in closed position. Again, this is the condyle, this is the fossa, and this is the disc, and this is the posterior part that is sort of a thick part, and this is the anterior part, and between them is sort of the thinnest. It's like a ribbon shape. The thinnest part is in between the anterior and posterior band, and far back here this disc is attached with the posterior tissues. We call them retrodiscal tissues, and the retrodiscal or the posterior attachment is highly vascular. It provides the blood supply, it provides the nutrients to the disc and to the synovial fluid here. It is important that you know that the disc is avascular and does not have nerve endings. So if we cut or squeeze this disc, there would be no pain. And the nutrients are provided by the synovial fluids, and the blood supply and the innervation is only present in the posterior attachment here. Here are the pterygoid, the superior and inferior lateral pterygoid, and you can see the superior lateral pterygoid is attached to the disc, and the inferior part is attached to the condyle. So when you open your mouth, now the first movement is rotation and then translation, and upon translation you can see that the posterior attachment is stretched forward, and the lateral pterygoid as an opener would also contract, pulling the disc and the condyle here, pull them together to do the gliding movement. So this is how it looks like when the jaw is open, and here when it is closed, it is just in the fossa, and here it moves over to the eminence part. So this is the normal mechanics, let's say, of the jaw. This is again the disc. This is the posterior attachment, which is highly vascular and innervated, the lateral, superior and inferior lateral pterygoids, and when you open, it moves forward, the disc moves with the condyle, and the maximum opening, the lateral pterygoids are contracted, and the disc is stretched, it's over the condyle, and you can see here the retrodiscal tissues are also stretched, and when you close, things get back to the initial position, and the retrodiscal tissues goes back, the disc is over the condyle, and here now the muscles are relaxed. What can go wrong in the TM joint? Different classes of disorders or types of disorders that might affect the joint. The internal derangement, inflammatory conditions, hyper or hypomobility. In the internal derangement, it means that there is abnormality in the mechanics of the joint. The disc would be displaced either with or without reduction. So this is one class. The second class is when there is inflammatory conditions, whether just inflammation in the capsule that surrounds the joint, or maybe there's inflammation in the retrodiscal tissues that has the blood supplies and the nerves, or maybe there is inflammation of the bone, and in this case it is arthritic changes. It's either osteoarthritis or rheumatoid arthritis, as we'll see later. Hypermobility, which means that the jaw moves more than it should, and it could be luxated or subluxated. So this is two forms of hypermobility. And hypomobility, where the jaw cannot move adequately because the most common cause is being ankylosed. So we'll talk about these disorders. Why do these disorders happen? The main cause is there's something that interfered with the mechanics of the jaw, probably, and the most common is trauma. So the trauma could be just direct trauma, we call it macro trauma, like the patient received a blow, not necessarily to the joint itself, it could be on anywhere in the face, even having a car accident where the patient have a whiplash, we call it whiplash injury, that like when your car got hit from the back and your head moved forward and backward. So this would provide sort of a concussion type of injury to the joint. So trauma, either direct or indirect trauma. Parafunctional habit, which you are providing or doing more job than is supposed to be, or than your joint is designed to tolerate. So your joint is designed to tolerate your talking activity and your chewing food activity, but if you do clenching all the time, if you do grinding during the night, if you are chewing gum all of the time. So this is excessive activity, and this will lead to a TM joint problem. And other people, there might be, they are not clincher, and they never had a trauma, but still they have a joint problem, sometimes because there is a problem in the joint itself. And one of these problems is joint laxity, which means that this person is sort of having hypermobile joints, and the jaw can open or stretch more than it should be, and this would induce trauma to the joint. Sometimes because there is sort of inflammatory condition, and as being a joint, the TM joint would be affected as any other joint of the body. So usually patients would have osteoarthritis of the knees and and the hands, and as well they might have it on the TM joint as well. Or if the patient is having rheumatoid arthritis, he might have it in the joint. Having occlusal problem, historically it used to be blamed for a joint problem. Then later studies showed that the occlusal disharmony, let's say, is not to blame for a joint problem. Only few occlusal problem like skeletal open bite, deep class 2 bite, loss of more than, like having free and saddle, for example. So there is no sort of support for the endpoint, one of the endpoints of the joint. So these major occlusal disharmony might affect the joint. However, like simple crowding, simple discrepancies would not actually affect the joint, as long as the bite is stable. So these are the etiologic factors of temporomandibular joint, or here I'm saying TMD, but I'm referring to the joint problem. It is very prevalent condition. Usually I see patients like teenagers, and the older age group are usually suffering from osteoarthritic changes or rheumatoid arthritis. In children or in young adults, I usually see patients with either muscular problem, or in the joint I see them with disc displacement or internal derangement problem. It is more common in females than males, probably because of the joint hyperlaxity, or maybe because females tend to suffer from pain more than males. It is very prevalent, as I said, in the population. However, not all patients would come and see or seek a doctor for this problem unless it is so severe, like when the patient have severe pain or limitation in mouth opening that would affect his daily activity. In this case, the patient would come and seek for dental or medical treatment. But the rest of the cases are, so the patient tend to manage these cases and live with it, and it's sort of a self-limiting. So this is the end of part 2, and in the third part I'll be talking about how to examine or the assessment of the TM joint. See you then. Thank you. Bye.